Hi, my name is Isabella, and today I'll be talking about post-operative pain, the assessment and management techniques. Pain is an extremely common experience patients suffer from following surgical procedures. Post-operative pain is most commonly due to tissue damage or nociceptive pain. Providing patients with early effective post-operative pain management allows for better clinical outcomes for early and long-term recovery. Long-term problems are caused by barriers in the healthcare environment, which include nursing implications, misconceptions of pain, and the overuse of opioids to relieve pain. When nurses do not assess pain adequately, they cannot manage and treat the pain as accurately as possible. This puts the patient in a high risk category for long term complications that can lower their standard of living. Chronic pain occurs when pain is not managed correctly and does not subside within 2 months or within the expected recovery time. Prolonged opioid use is another issue where patients can experience several adverse effects such as toxicity, bowel dysfunction, respiratory depression, and have a tolerance against opioid drugs. Postoperative pain can be distressing and anxiety-filled time leading to psychological issues. Extended recovery times also negatively impact the health services as it increases the length of stay, increases the risk of unanticipated hospital readmissions, and the need for management services for outpatients with chronic pain. In 2017 to 2018 in Australia, there were 352,000 emergency admissions to hospital that required surgery. There were also 2.3 million admissions for elective surgery. Around 75% of these patients that had surgery experienced moderate to severe pain after the surgery. 10.3% of patients that suffer from chronic pain was due to prolonged postoperative pain. These numbers are alarming and the level of care for these patients must rise. Changes need to occur to current practices to improve outcomes for postoperative care. High-quality pain management is defined as performing a comprehensive pain assessment that involves a screening of the presence and severity of pain and continuously reassessing the patient's response to the different pain treatments. The current health situation in Australia includes the following pain management and assessment practices. Pain assessment should be done regularly to monitor the severity of the patient's pain and to monitor if the management treatments are effective. There are several pain scales that are used within the healthcare setting. According to the South Western Sydney Local Health District, for patients that are awake and responsive, the best tools to use are the numerical rating scale and the FACES pain scale. These scales can also be useful for children and for patients from a non-English speaking background. For patients that are unresponsive and mechanically ventilated, the best way to assess the pain is by using the behavioural pain scale. The acronym PQRST can be applied as a guide for nurses while they're doing a comprehensive assessment of pain. The between the flags method can also be applied when documenting pain on a SAGO chart. This is when nurses document vital signs and can follow the trends of their vitals and pains before and after the administration of pain medication to assess whether it is relieving the pain. If these vital signs are out of the normal range, it can also be a clinical indication that the patient is experiencing pain or adverse effects of the medication. Before surgery, a care plan is to be developed that is specific to the individual's needs according to their comorbidities and their preferences of care. It is important to engage patients in creating the care plan with support from the multidisciplinary team so it is catered to their needs. For 48 hours after surgery, opioids are to be administered to relieve pain. This can be given when needed or through a PCA or NCA. A PCA is patient-controlled analgesia where patients have control over how much pain medication is given by clicking a time-controlled button that releases opioids through an IV access. There is a lockout system in place so only a certain amount of medication can be administered within a certain amount of time to reduce the risk of oversedation. An NCA, which stands for nurse-controlled analgesia, is a similar concept as a PCA, but the nurse has control over how much medication is given. A multimodal approach to pain management has been shown to have great effect on patient outcomes. It incorporates the use of several different classes of analgesics that act by different mechanisms and at different receptor sites that provide additive or synergistic pain relief. Heat therapy is also a useful tool to relieve pain. Patients can use heat packs, hot moist compressors, a hot water bottle, or get into a hot bath to expose their whole body to the heat. Another treatment option is cold therapy. Ice bags or towels soaked in ice water can be placed on affected areas to help patients deal with pain. Patient positioning can also help to improve the patient's comfort. There are several barriers that limit the use of different assessment and management practices. There is a range of issues when using scales to assess pain. Patients have difficulty in describing their pain by only a number or a point in the linear scale, which means that the full extent of their pain is not being expressed, which can lead to pain being mistreated. Pain is a subjective experience that is different for all patients. Therefore, a patient may think their pain is severe and above a 7 out of 10, whereas a patient may also be experiencing worse pain but think their pain is only a 5 out of 10. Patients may also not want to express their pain as they don't want to be a burden or have nurses think they are overreacting, which then leads to prolonged pain after surgeries. The teaching of pain may not be very in depth, which may leave nurses feeling like they have inadequate knowledge to treat a patient's pain. There is also a misconception within the healthcare system that nurses hold the power over the patients and the existence of the patient's pain, and they can determine how much pain the patient is in. Nurses can have a negative outlook on patients suffering pain, which leads them to disregarding and misjudging the severity of the pain the patient is experiencing. The World Health Organization has recognized handover as one of the 5 challenging patient safety problems. As the patient will transition through multiple wards, it is important that the handover is as accurate as possible to ensure all aspects of their care plan are delivered to all carers. If all the information is not delivered, some crucial aspects of the care plan may be left out, resulting in prolonged recovery time and a distressing ordeal for the patient to experience. The There are several strategies that can be put into place to support closing the gap of post-operative pain. My first recommendation is to do with nurses' misconceptions of pain and undereducation. It is crucial for ongoing plan education to occur within the hospital setting and in under and postgraduate degrees. In-services are a useful tool in the hospital setting where nurses have to attend lectures on post-operative pain and the ways to treat it. This allows for the opportunity for nurses to feel empowered when providing post-operative pain treatment. These education programs should take into account the hospital policies and supplies and the nurse's workload so that it can be implemented into the hospital competently. My second recommendation is to ensure handover is complete and efficient. A standardized protocol of clinical handover should be used across the whole hospital. The use of ISBAR develops a structure whilst providing handover to ensure that no information that may compromise the patient's safety is left out. ISBAR stands for Introduction, Situation, Background, Assessment, and Recommendations. My third recommendation is increasing the frequency of assessments of pain. This will allow medications to be given at appropriate times to reduce the period of time that the patients are suffering. For example, giving medication before a physiotherapist session, before a wound change, or before a shower. This would increase patients' comfort. My fourth recommendation is preoperative education to patients, as this is crucial to ensure the patients feel like they're a part of the pain management decision-making process. Patients fully informed of all options they have following surgery will make them feel empowered to express their pain to the nurses after. This education leads to less preoperative anxiety, reduction of opioid administration, and the length of stay after surgery. Using pain scales that are appropriate to the age and nationality of the patient will also allow a more accurate representation of their pain. To conclude, post-operative pain assessment and management is extremely important to ensure patients recover effectively without being put at risk of long-term complications. Closing the gap and eliminating barriers can be done by educating both nurses and patients, as well as ensuring pain assessments are thorough and timely, and ensuring handover is complete and includes all aspects of the patient's case. Thanks for listening, and I hope you enjoyed.